This is actually the title of the presentation, which is essentially the title of the grant, the UO1 that we just recently were awarded by NIMH. The brain stimulation for chronic auditory hallucinations in treatment-resistant schizophrenia. I like to start usually my presentations about DBS with this beautiful painting by Hieronymus Bosch, was it Dutch?
Sorry, Nicola, one more point, and that is we can see the slide thumbnails on the left. We don't see the full screen presentation.
Oh, really?
Are you clicked on the full screen?
Yeah, I am actually.
Oh. No.
Yeah, let me see if I can get some help from.
You're clicked on that. You know the icon on the bottom right.
Oh, okay, got you.
Yeah, that's good. Perfect.
Is that okay?
That works. Yeah.
All right. Yeah. All right. And so this is beautiful painting, an allegoric one, of course, of from Bosch, which is at the Prado Museum in Madrid, and it's titled the extraction of the stone of madness. So, of course, being an allegoric painting by Bosch, the surgeon here has a funnel on his head, and one of the woman actually has also a book, which can be also an indication that she was not right in terms of her mental health. And so there have been attempts to actually treat mental illness through surgical interventions over centuries, even millennia, if you want. But if we go to the more recent times, and I think in one of the cheers from the chair, Jimmy, you mentioned Robert Heath, who actually attempted, here is depicted in this picture, trying to use this sort of stereotactic method to implant the electrodes down deep in brain structure. And of course, in 1955, CT MRI were not available, and they would use ventriculography, pneumoencephalography in order to visualize as much as they could the brain area where Heath thought that would be therapeutic for patients with schizophrenia. They implanted several deep brain structure, including the head of the caudate and the amygdala, of course, with results that were less than therapeutic, we would say. And in fact, by the end of his career, actually, he stopped doing this type of intervention because he didn't see any long-lasting benefits to his patient. It's interesting that the second author of this paper is Russell Monroe, who actually would go on to become chairman in the Department of Psychiatry in the University of Maryland, just across town. And but this is DBS today. So what is DBS? Essentially, is the delivery of an electrical current to certain parts of the brain, and through an electrode, and the current which is delivered to, let's say, here is depicted thalamus and the subthalamic nuclei here, which is usually the site, one of the sites for treatment of Parkinson's disease. The stimulation is delivered through very tiny, small electrodes, and which have different contacts, up to 4 contacts spaced by each other by a distance of 0.5 millimeters. And the length of the contact is about 1.5 millimeters. And the electrode is actually through a cable channel through, goes to a pulse generator that is implanted under the clavicle and provides, of course, the stimulation to a certain frequency, pulse width, and certain amplitude that can be, of course, programmed at the time of the onset of the stimulation. So this is the kind of, I mean, I took it from Lozano and Lipsman, but shows the number of publications per year about DBS. And but the important thing is to see the dates where, you know, the DBS was started in patients with Parkinson first. And when the FDA, for example, approved the DBS for essential tremor in 1997, and then it took about 15 years to approve DBS in Parkinson's disease. In 2003, it was approved for dystonia, and in 2009, FDA approves DBS in OCD and treatment-resistant depression with the humanitarian device exemption. I don't know if you can see here on in 2011, the FDA approves an investigation of device exemption for schizophrenia, which is what we have today. And so how did we get to our first case that we'll show today? So we had two things to make a decision about: which patient to use, and of course, what part of the brain we would like to stimulate, and or modulate, let's say. I think it's better modulating. So we started working on the protocol in 2010 with Fred Lentz from the neurosurgery department of neurosurgery here at Hopkins. And then Lauren Moran was our PGY4. And Lauren moved on, you know, currently she's at McLean at Harvard. Fred Lentz was replaced, it's a bad word, but Stan Anderson took over from Fred. But, you know, our protocol was approved by the FDA, granting us an investigational device exemption in 2011. So FDA said, you can study 3 cases, and just to show safety first, and then eventually efficacy of your intervention. Our IRB at Hopkins approved the protocol in 2011, and we registered our course study at clinicaltrial.gov with this number. In fact, you know, our first case, you know, got to us through clinicaltrial.gov. So she contacted us in person, actually. So what are the criteria that we chose for our patients? Males and females who are at least of 22 years of age and over, with a diagnosis of schizophrenia or schizoaffective disorder. And subject was determined to be treatment resistant. And Jimmy used the expression ultra treatment resistant, which is correct if you want, because TR for at least 1 year prior to the screening visit. And essentially the criteria, they had to fail, you know, 2 antipsychotic medications and a trial of clozapine. So they are resistant to treatment with clozapine. It's that subgroup of patients who do not respond, and can vary between 15 and 30% of the patients who are tried on clozapine and do not respond to the medication. And so they had to have trials of different antipsychotics for at least from 2 different classes, for at least 12 weeks, equivalent to at least 500 milligrams of chlorpromazine within the previous 5 years. And this is taken from the clinical trial that John Kane did when clozapine was reintroduced in the United States in 1989. A trial of clozapine of at least 12 weeks at a dose of at least 400 milligrams with a blood level of 350. But, it's also true that subjects who were unable to tolerate clozapine or because of intolerable side effects were also eligible. As far as the severity, we chose, at least as our first patients, to go through the trial. They had to have at least a score of 6, which is an index of severity, on 2 of the 4 BPRS positive symptoms, which is conceptual disorganization, grandiosity, hallucinations, and unusual thought content, which is essentially all type of delusions that the patients with schizophrenia would eventually have. One of the 2 positive symptoms must be hallucinations, of course. And the severity here is that the hallucinations or the symptoms must be present daily and have a moderate impact on the patient's behavior. Now, exclusion criteria, besides the ones that typically are part of a clinical trial, of course, subjects has a diagnosis of mental retardation. And the important things that we really wanted to make sure the patient with unstable psychosocial condition, including housing and poor support, were excluded from the study. And our 3 patients, of course, had all met criteria in terms of having stability, living with family, and so we would not incur the risk that they would be lost to follow-up, if you want. So why auditory verbal hallucinations? So we want to show you a little bit of the epidemiology of AVH and schizophrenia, which afflict more than 80% of persons with schizophrenia. Of course, they can lead to both suicidal and aggressive behavior. AVH resists treatment in 10% of persons with schizophrenia at onset of the disease, 30% over the next 10 years, and a substantial amount, about almost 50% of the patients by 20 years post-onset. Persistent AVH predict reduced work attainment, like in our 3 cases, even after controlling for global functioning and delusions. So there is a specificity of the impact of AVH on the patient's functioning. The presence of AVH during the first 3 years of follow-up predict a reduced likelihood of achieving psychosis remission over the next 18 years. AVH appear to specifically impair source monitoring and speech perception on cognitive tests. They also may sustain delusions, which suggests that ameliorating AVH could potentially treat delusions. And I think in our 2 of our 3 cases where delusions are clearly intermingled with the hallucinations, we have achieved partly that goal. And just to remind you, for those of you who are not familiar with the domains of psychopathology and schizophrenia, here, the domain of cognition, which are impaired, of course, hallucinations, delusions. These are what usually people call positive symptoms. And here, there is an overlap, of course, with recognition of what we call negative symptoms, as like lack of social drive, poverty of speech, diminished emotional range, flat affect or blunted affect that people would be more familiar with. Now, the interesting things about these domains that partially overlap is that they are subserved by segregated parallel corticostriatal thalamus cortical circuits. And I have two pictures of this, but it's kind of interesting where to see that, for example, the ones that like STG, the superior temporal gyrus, here goes to the caudate or the ventral striatum. And but what is common to all of these, parallel segregated circuits that subserve different brain functions from motor to cognition and perceptions, is that the common pathway all goes to the substantia nigra pars reticulata. So, and then returns to the through the thalamus, goes back to the cortex where they came from. And in fact, this other slide shows better the sensory motor and premotor cortex that goes through the I don't know why it jumps through. Okay. And here is the cognitive one, the dorsolateral prefrontal and lateral cortex. And here GPI plus SNR, and it goes back to the thalamus. And here is the limbic, which is usually associated with positive symptoms of schizophrenia. And these are the cognitive. So what we thought is that through modulation of a circuit that comes from the cortex, goes down to the common output of the basal ganglia, which is the GPI SNR, and we would modulate this circuit and hopefully treat the positive symptoms of schizophrenia, including hallucinations and delusion, affect somehow, of course, cognition, because there is some shared pathway there. And in fact, this is a basal ganglia circuit. If you go back to this slide here, is the ventral striatum. And this is what, other people using DBS in schizophrenia have tried to do. Have implanted the nucleus accumbens and with a hope to treat positive symptoms of schizophrenia. And in fact, by the time we wrote the protocol, it was not known to us that a group in Barcelona was implanting patients in the nucleus accumbens. And this is taken from the paper by Corripio and colleagues in Barcelona, published in 2020. Keep in mind that our protocol was written in 2010, and we got the IDE in 2011, and we had to wait about 9 years to to implant the first patient. And but what they actually, these are 3 patients that they studied, and indeed they were able to show some decrease in PANSS total score and over time. These are 8 months after stimulation of the nucleus accumbens. But the problem with the nucleus accumbens is that stimulation with high frequency of this nucleus is indeed associated, at least been associated in patients with treatment-resistant depression with onset of acute delusions, with stimulation over 4.5 volts. And Barcelona, they used high voltage when they were stimulating the nucleus accumbens. and so the risk is that you might worsen the positive symptoms of schizophrenia. And here we come in. So this is our substantia nigra parsa reticulata that we proposed to implant in our patients with chronic hallucinations and delusions. And modulation of this nucleus will potentially modulate the activity of the thalamus, especially the middorsal nucleus of the thalamus. And by doing this would then affect the cortex. And so originally what we really thought was that we had to modulate the thalamus because it's hypoactive in schizophrenia. And so inhibition of the inhibition eventually of the SNR would activate the thalamus and then the cortex. And we have some evidence that that I will show you later about frequencies of EEG in actually field potentials of SNR in the gamma band. By decreasing that gamma band, we show an acute resolution of the hallucinations. So these are our 3 cases that we have implanted so far. And these are, as we said before, patients who have not responded to clozapine or were unable to tolerate the medication. Our first patient and I wanted to show you, I mean, this is a virtual grand round. Originally, we were supposed to be a hybrid type of presentation. And so I was planning to invite one of the patients to be interviewed by Jimmy, but unfortunately the hard all was taken over by our dean today for the town meeting. So I have recorded and with the help of Dr. Butala, who has done a great job in editing the video recording and presenting. I wanted to present to you what the patients reported acutely and after several months of their stimulation. We presented our first case as a case reported biological psychiatry in 2021, and but I would like you to. She became ill at age 19. By the time we implanted her, she had a 16-year-old history of schizophrenia with chronic auditory hallucinations and delusions that were not responding to clozapine in the past, but she gained an enormous amount of weight, so she had to stop the medication. And the implant was done on the 27th of January 2020. Usually we put the pulse generator under the clavicle 1 week after the surgery, and we started the stimulation 5 weeks after and of course, all the patients have given consent to appear on video, and the consent was collected at the time of when we recorded the programming. And so this is the
tell us about those. So we're going to slowly back. I'll just tell you as soon as they start. So, just.
Yeah, unfortunately, Nicole, I think it's hard for us
Nicole?
to hear it clearly.
If you're able to,
What did you say, Jimmy?
Nicola, yeah, I don't, unfortunately, I don't think it comes through. The audio doesn't come through very clearly.
Oh,
if you're able,
really?
if you're able to exit the presentation, you can set it up for streaming. There's a Zoom option for that.
For the,
I think the host might be able to do that.
Yeah, unfortunately, I'm not sure we're going to be able to do that on the fly.
oh, really? So let me see if I increase my volume.
No, it's not the volume, it's more the
Oh, the recording.
coherence and consistency of the, I know it's an
Oh,
issue
really?
I know is a known issue.
All right. But, the gist of it is that, at 1.5 amplitude volt of stimulation, the voices have disappeared, and lowering it, the patient reported an acute recurrence of the hallucinations. Here, in this cartoon, in this model, actually, you can see the electrodes with their contacts, and they are, as you see, this is the SNR, and this is the one that we are using. The contact is the most, the second to the deepest one of the contacts. Let me see if
Yeah, Nicole, I can't hear a thing.
I am sorry. Okay. Well, I mean, this is taken by our paper, our case report, and but as you can see, delusions and hallucinations were down the scale of a BPRS between 1 and 7, and they came down at 6 months after stimulation to 1. And these are some of the negative symptoms that the patient was experiencing before and after the stimulation. This is the second case that we have implanted, and we have some traptography, which shows the connection of the SNR to this gyrus and medial prefrontal cortex. This is the same subject, and the big blob, of course, is the thalamus. This is the red nucleus. This is the just a second. And this is the SNR, and this is the electrodes that we implanted. And these are tracts that would go to the SDG. I hope that this could be better. You can tell me, Jimmy. Oh, it's broken. This is the second case when she was on Maya 5 before the surgery. And one of the things that the patient does, or used to do, was quite shaky and fidgety with her lower extremity, and she would snap her fingers in an attempt to control the hallucinations. So I don't know if this is better.
No,
No.
doesn't work.
So it's I pasted the instructions on how to optimize in the middle of the presentation.
Yeah, Encore, I'm sorry, but I just, unfortunately, I don't think it works for us to try to fix it on the fly.
Okay. All right. And this is from 1 week ago when the patient came. I can tell you then. So the patient had a relapse, a return of the hallucinations in February. So we got her back for a programming session a week ago, actually. And this time we were able to keep her overnight, Marriott across from Hopkins, and because we wanted to check if the settings of stimulation that resulted in improvement of her hallucinations were indeed whole, was the case. So we rechecked her on Tuesday of last week, and she was doing better in terms of hallucinations. She was able to tell us that she returned to being control of the voices, although, of course, she was hearing them, but they were less powerful, and more, she was able to control her. The interesting things about this patient, and I'm sorry that we could not really hear her, is the degree of improvement of her negative symptoms that, indeed they were secondary to the ones. This was a patient who actually had stopped clozapine at one point, a couple of years before that. And the patient relapsed. At the time when she stopped, she was still working part-time at a local library. And but the return of treatment with the clozapine failed to resolve the positive symptoms of her disease. And then we were contacted by her psychiatrist who actually had read our paper, and we screened the patient qualified for study. And the interesting things, after let's say 3 to 4 months, when the hallucinations decreased in terms of impact on her behavior, she was able to, as she said, with her own words, sitting idle, listening to the voices, but now I can do house chores, I can drive, run errands, and interestingly enough, with her stepfather and her friend and his friends, she is able to play cards on each Saturday for a couple of hours, such that her concentration attention has greatly improved. She has returned to read books, which was something that had stopped doing. Now, this is our third case, and I don't know if the video recording will be better this time. You can tell me, Jimmy.
No, not hearing it.
Are you hearing anything?
No.
Okay, so this is our third case, and we have some interesting traptography that were done at Mount Sinai by our collaborators, Dr. Fiji and Dr. Choi. And it very clearly, from the volume of tissue activation, the VTA, it's not the ventral tegmental area from where dopaminergic efferents go up to the mesolimbic and mesocortical area, but it's the tissue that is activated by the stimulation of the electrodes. And there was a clear track that went to the superior temporal joints, which is that part of the brain that we would like to modulate. So unfortunately, I had to skip this But I have to say that we use the Likert scale at the time of the stimulation, and he started the programming with a severity of 7, between 0 and 10, and he left Hopkins that day with a severity of 1. He said that the voices were still there, but they were very, very quiet. We got him back three times, and this is one recent one, but I have to skip this because, of course, if you cannot hear, but and I don't know if you can hear the interview with his wife that I recorded from my house Wednesday of last week. Let's see if it's better. Do you hear anything?
No.
Again, it doesn't have to do with the audio presentation, the
okay.
audio quality of the study. It has to do with the Zooms.
All right. So now I'm sorry for this, and maybe we should have done a better things with, but for one thing that one of the biomarker of the stimulation is a band of the EEG, which is usually which goes from 10. And there is evidence, at least from the cortical areas, that there is a correlation between auditory verbal hallucinations and left-right gamma synchrony in the auditory cortex in patients with schizophrenia, as well as there is a reduced, prefrontal auditory gating in the gamma band, schizophrenia versus controls. So we have evidence from our own study that indeed, as you can see here, by decreasing the gamma, this is in patient number 2, and by decreasing the local field potential of the gamma band, and by cranking, of course, up the amplitude in milliampere, there was a response of the patient. This is the right and the left SNR with an acute response in terms of improvement of hallucinations. And one of the things that we are planning to collect information about, we have some already from our second patient, and this is part of our UO1 study, is to collect real-time information about severity of hallucinations and delusions of our patients who get implanted. So these are called ecological momentary assessment of hallucinations, and this is taken by Phil Harvey, and who is one of our collaborators for the UO1, and then we will ask the patient to annotate the LFP recordings by pushing their device, and such that we can have real-time severity of hallucinations with local field potentials in the presetted gamma band, and that's really, quite unique in terms of studies of patients with schizophrenia. What we are planning to do is to, of course, unknown to the patient, but to avoid placebo effects, we turn off for 2 weeks the stimulation, and then of course, 4 days before they come back to Hopkins for the visit, we'll record, the local field potential, and at the time, of course, during those 4 days also, we can get the ecological momentary assessment of severity of hallucinations. We have collected also, neurocognitive testing from our patient, and with the help of David Schretlen and the psychometrician Mark Yoon, I can show you some of the results that we have obtained. This is our first case. It's labeled 003 because we consented 3 previous patients, although they didn't go through the surgery for various reasons. And these are the domains of cognitive functioning, processing speed, attention, or verbal fluency. And as you can see from, the pre-surgery, while the DBS is on for about 6 months, and then 1 year almost after this was activated. David told me that the results of the first 3 cases from a neuropsych testing point of view are a little bit messy, in the sense that usually, patients with schizophrenia, even with, patients who are chronically hallucinating, they tend to have like a stability in their response to the testing. But, our patients were a little bit all over the place. Although for some of the function, you can see some, improvement from baseline, but there was, up to, 6 months, some of the those improvements were almost a return to baseline, if you want. Like, for example, ideation fluency, although the executive function was, improved at 6 and 12 months. This is our second case, and again, showing some improvement and return to baseline. And then our last case, which has just hit the 6 months of stimulation. Executive function was not that great, of course. And so this is what, David would say it's pretty messy here, because, it's unclear why those patients would score worse than the pre-surgery at this point, not in some domains. I think, I apologize again, because I wanted to show how the patients in person responded to the treatment. I can return that. Maybe we can arrange for another quick grand round when we get those interviews streamlined.
Nicola, I shared a folder for all the videos in the chat, which I encourage everyone to take a look at. And if you like, I can show some of them now if I take over screen sharing.
Yeah.
No, actually, I'm sorry. Let's just keep going. Are you at the end of the round, Nicola?
Yes, I have my.
Okay.
Thank you.
Let's do questions. I think
Definitely.
the video is it's a little too complex to sort out right now with all.
Okay. So these are my collaborators.
Let's keep going and let's do some questions. Yeah.
From our department, neurology, with Kelly Nielsen Butala, Stan Anderson, Youssef Salimpur, JHU Biomed Engineering, Laureano Najim, the director of the lab. And these are our collaborators at Mount Sinai and University of Florida. These are all part of our U1 upcoming study. And this is a picture of myself. My daughter said I am the shortest Italian psychiatrist. And this is Stan Anderson in the operating room with our first case. This is Kelly Mills. And the photographer was Ankur Butala that day in January 2020, 3 years ago. Thank you very much. Sorry again about the massive pictures. And
that's okay. Thank you. Thank you. So, Nicola, I'm not sure if you explicitly said to everybody, and people may know, because I know I mentioned it in Cheers from the Chair, I think you were just formally awarded this NIH grant to continue this work.
yes.
So that is a very exciting new development that's going to fund this work for the next several years. And I guess you're going to bring more people into the study. Now, I think I understand that people have to be pretty ill to get into the study.
Right.
But on the other hand, they can't be so ill that they can't be followed up. So am I right that there's kind of a sweet spot in between? You can't have the most severely ill who you can't follow, but they have to be pretty ill. And I guess what I'm wondering is, do you have a sense of how many people are in that sweet spot? Are there lots of, in other words, will there be lots of candidates for this study, or will it be hard to find people?
Well, I mean, I would hope that, as you said, that sweet spot is, will bring in more patients. And I agree with you. I mean, those ones that cannot, and this was also raised by the reviewers of our grant, because, how, can, for example, a patient who has so severely ill based on, the inclusion criteria can manage, for example, to respond 3 times a day to the EMA, to the ecological momentary assessment, or, for example, annotate their gamma band local field potential. So I would hope with you that, of course, the number of patients are indeed bigger than those ones that are unable to really participate into the study. Yes.
Okay. Cool. We have a question from Albert Barnaby. This is such an amazing study, and we've taken care of the last 2 study patients on Meyer 5. With the clozapine, 12 weeks of the medication trial was mentioned. What about for those where ECT was initiated? How many ECT trials would you consider prior to considering the deep brain stimulation study?
Right. So it's not a criteria of inclusion for us that you have to have like ECT, and was not raised also by the reviewers for our U01 grant. But I would, if a patient, by their treating psychiatrist decides to have an ECT course cycle to see if they respond to ECT before doing the DBS, that's okay also. Of course, we would accept that type of patients in our study.
Okay. Ray DePaulo says, the work you and others are doing are giving significance to support the seeing psychotic illnesses as disorders of brain circuits. The question I have is whether you believe we might eventually achieve equal benefit and less risk using a well-targeted TMS intervention. Any reason to think yes?
Yeah, that's a good point, Ray. But so the thing is that how deep the the TMS can go, to affect the circuits that is the output of the basal ganglia and then the thalamus and go back to the cortex. So one thing that the risk associated with, of course, there is a risk. One of the patients, for example, in Spain, got a stroke during the placement of the DBS device and was, of course, removed from. I'm not sure if he survived after the stroke, but it's a real risk. But in the hands of people who have done hundreds of DBS in Parkinson and movement disorders or OCD and TRD, the risks are minimized. The other thing which is also important to realize is that our population is much younger than the patients with PD that tend to have DBS when they are in their 60s or even 70s. So the morbidity of the intervention is much lower, I would hope, than although it's true that our patients have comorbidity, like, they are obese, they have, high blood pressure. Sometimes they smoke a lot. They have a huge, risk associated with smoking. But 2 of the 3 didn't smoke. The first one actually was a big-time smoker and continues to be a big-time smoker.
Thanks. Tom Sedlak says, in a remarkable convergence, you are aware that Stanislav Zarenko independently identified the thalamus as crucial in a mouse model of auditory processing and possible hallucinations. Does the mouse thalamus have enough similarity to the human one to know how similar the nuclei you are targeting are?
There are similarities, but there are, the thalamus is of course much bigger in humans because of the function that took over from other mammals. And yes, I'm aware of those type of work. And another interesting thing is also the relation between the SNR and the inferior temporal gyrus, which has to do with visual hallucinations. And so it's possible that by modulating the SNR, we can treat or improve not only auditory hallucinations with the STG connection or functional connection, and also with the visual hallucinations if the patient is affected by visual hallucinations.
Nicola, when I mentioned this to someone recently, they asked the question about how generalizable might this approach be to people with schizophrenia. I mean, of course, we just talked about how you're targeting a narrow slice of patients right now for good reasons. Is there any way of getting a sense of whether this might more broadly be applicable to a large swath of people with schizophrenia?
Yeah, I mean, my hope is that, that's the same question that reviewers asked us, when we submitted a grant. How generalizable is, does make sense to just limit, for example, this DBS intervention to treatment resistant or ultra treatment resistant. The point is that, if we see results that are significant, then my thing is, then we can apply for a humanitarian device exemption, and then we can show to the patients, to the scientific world, then I think we can eventually propose the use of DBS in patients even before going to clozapine.
You say before going to clozapine.
To clozapine, yeah. And the thing is that would the patient and the family agree to that? So that's the key also too. But if we show that there is indeed, clozapine is associated with lots of risk, of course. It's not an easy drug to be on. Weight gain and cardiomyopathy. Although the risk is, it's a very small percentage of patients, so forth. But if we have to generalize the use of DBS to a wider, schizophrenia patients group, then I think we have to seriously think that after maybe 2 trials of neuroleptics, then maybe could propose DBS as as an intervention. But I don't know if we'll get to that point. Of course, yeah. It's kind of I don't know, when people hear about neurosurgery, of course, it's scary, you know. And I still think we live under that, you know, shadow of psychosurgery, of, you know, leucotomy, lobotomy,
Right.
you know, that were done between 1934 and 1954, before the advent of the neuroleptics.
Yeah.
And, you know, it's kind of, I reviewed a little bit the literature of that, and it's kind of interesting that, you know, in the US, there were lots of lobotomies and leucotomies done, but none of that was done at Hopkins.
Interesting.
Yeah, at the time of Meyer. Meyer agreed to do that, but I don't know, you know, Cushing was the surgeon in 1936, but, you know, and Egas Moniz, the Portuguese neurologist who started the lobotomy, the frontal lobotomy, he got the Nobel Prize in 1949 for such intervention. Yeah.
Interesting. Well, Russ Margolis makes a comment, which might be a good comment to end on, which is that Fred Nucifora's work, he says, on treatment-resistant and ultra-treatment-resistant schizophrenia may prove of considerable value in sorting out how to prioritize use of treatments next week's grand rounds. I didn't realize that.
That's good.
That is good. That's a
We
perfect.
will follow that. Yeah.
Yeah, that'll be.
I hope if he has any recording of patients, he can learn from my family.
Exactly. Well, that was very interesting. Gosh, yeah, we all wish you best of luck in this project going forward. It's fascinating work.
Thank you very much, and thank you everyone for attending this grand round. Yeah.
Great. Thanks. Take care, everybody.
Okay. Bye-bye.